Thank you all, and thank you all for tuning in. I'm presenting the class of 2016 AAHU Science Treatment College Symposium. So the fellows have been through 9 months of intensive training, and today they're presenting their final symposium presentation. So the first presentation up is Aaron Davis from Baltimore, Maryland, and give him a round of applause.
Good morning, everyone. Good morning. It's too early. I know I'm the first one up, but good morning, everyone.
Good morning.
All right. I have the tremendous task of starting off today's presentation and setting the tone for this group, which I'm excited for the opportunity to do. As Eric said, my name is Aaron Davis. I am a HIV testing program manager and trainer with the Maryland Department of Health and Hygiene's Prevention and Health Promotion Administration. I know that's a lot to say. Just the agency that I work for, and I'd like to thank everyone for being here for the presentation. But before I begin, I'd like to, as Eric said, just congratulate everyone for this 9-month race that we have taken. It's been a long road. We're about to cross the finish line. So I just want to give everybody a round of applause. I see what you're going to be doing as well. And we're going to get started. Again, title of my presentation, Expanding HIV Prevention for Same Gender Loving Men and Community Faith. So as a representative of the state, we always like to show our mission and vision. FIBA is what we call it. We allow you to read on your own. But as you can see, as you read along, a lot of the objectives and goals of my administration really tie into why we're all here today, as well as ties into the goals of BAI, BTAN as well. But I will read the vision. So the Prevention and Health Promotion Administration envisions a future in which all Marylanders and their families enjoy optimal health and well-being. As somebody who has been living with HIV for the past 10 years, over 10 years, I can give you firsthand experience of what it's like going in as a young gay man to get your first HIV test and being stigmatized or feeling ashamed just because of basically who you have sex with. As somebody who's newly diagnosed, I can tell you what it's like essentially falling through the cracks and never being linked to care until actually I moved out of the small town I was in to the state of Maryland. So when I read this vision, it really just resonates with me, and it shows why I have a passion for the work that I do. It's the reason why I get up at 4:30 in the morning before the sun comes up, and why I brave the traffic from DC to Baltimore every day to get to work. Why I work hard to increase the capacity of providers to work with gay, bisexual, same-gender loving men, and why I go to bed tired and exhausted and get up in the morning and do it all over again. So when I see this, again, increasing the ability for Marylanders to have optimal health and well-being, I take that really to heart, because again, I don't want other gay, bisexual, and same-gender loving men to go through what I have to go through. And again, these stories are not common. It's something that's happening every day. So again, I want to prevent that with the work that I'm doing. And hopefully the project that I have to show you that it will also be able to do that. All right, so here's some just overview of some Baltimore, Maryland demographics and epidemiology. I'm going to list the problem statement that, as you can see, that comes out of those statistics. I'm going to talk about my AAHU training and internship experiences. So you're going to walk with me through that little journey through these 9 months. We'll talk about BTAN Baltimore, also talk about BTAN project proposal, and also talk about next steps and recommendations. So I'm going to ask you, for the sake of time, hold all questions until the end. I have a lot of information to get through, but I will definitely take questions at the end. Is that good? Absolutely. Let's start off with some Baltimore demographics. So we are not the capital, but we are the most populous city in the state of Maryland. About 621,000 individuals living in Baltimore City. Of those, 63% are Black or African American, about 31.6% are white or Caucasian. We also have a large population of youth and young adults. 20% of our population are under the age of 18. We have a quarter of individuals living under the federal poverty level, making around $24,000 a year. We have high rates of homelessness in Baltimore City. In fact, there was a census count that they did one evening, I believe, in February 2013, where they looked at just the homelessness in Baltimore City. They found that around 2,600 individuals were actually living on the street. And of those, 20% were actually under the age of 24, which is definitely a problem. We also have high rates of substance abuse. We have the unfortunate distinction in some circles of being known as the heroin capital of the U.S. So we have large amounts of injection drug use, and with that, unfortunately, high rates of hepatitis C infection. And also, we have about 37% unemployment among African American men aged 20 to 24, which is, again, one of those populations that I have a passion for working with. And as you can see, it leads to a lot of different health disparities. Let's talk about some Maryland epidemiology data. So this is data from 2013 for my administration. So in Maryland, in 2013, we had almost 31,000 individuals living with HIV. And this is not including the estimated numbers of people who may be living with HIV but not diagnosed. So of those, we have 1,396 new infections. Of those, 71% were male, 75% non-Hispanic Black, and 30% living with HIV between 20 and 29 years old. So as we see in Maryland, as with a lot of national data, most of our new diagnoses follow the trends, where we see young African-American men being the ones bearing the brunt of new infections. What's an interesting statistic is the bottom, 32.9% of individuals who are newly diagnosed in 2013 actually received an AIDS diagnosis within 12 months of their initial HIV infection. As we know about HIV and disease progression, takes about 8 to 10 years to progress from HIV to AIDS. So when I see that a third of individuals getting an AIDS diagnosis within that first 12 months, that lets us know that we are not doing our job to really adequately get people tested, get people diagnosed early in their disease progression. So we have a lot of work to do. All right, so continuing on with some 2013 data. So about, let's see, can't see that, 53% of new diagnoses were among men who have sex with men. They also accounted for 52% of late diagnosis. This table that you see is actually something fresh off the presses, and we actually presented this about 2 weeks ago at our HIV testing coordinators meeting, which is a statewide meeting for all of our FIPA supported sites. For those who don't know, Baltimore City became its own separately funded entity by the CDC a couple years ago. So the data that you see here is just representing all of the agencies that we support throughout Maryland, but not including Baltimore City. All right, so as you can see, we tested about 25,000 people over calendar year 2015. Of those, and I'm saying this because I want to talk about the targeting. Of those, only about 1,740 people were actually MSM. So very small number of MSM tested. However, they accounted for 54.9% of the new infections. And so that translates to a seropositivity of 2.9%. So again, we are testing a lot of people. We're testing a lot of people. And few of those are MSM. However, as we've seen in the data, they're bearing the brunt of new infections. Again, 54.9% of all new infections are coming from this population. So again, a lot of work to do. This is a graph that shows adult and adolescent HIV diagnosis trends by exposure category over a 10-year period. So from 2005 to 2014. And we look at exposure from MSM, IDU. We have a special MSM IDU category. We have heterosexual sex and others, so people who get a particular risk. So as you can see in the green, which is the heterosexual sex, it's been fairly constant over the past 10 years, hovering around at 40%. In the red, which is our IDU, which used to be second in 2005, has dropped down significantly. Again, and that's really in part because of what the city has done with our needle exchange program. So I'm actually happy to report that our state legislature approved for the rest of Maryland just the past couple of months. So I'm actually really excited that we can do needle exchange in the rest of Maryland. However, the blue line is what I want you to draw your attention to. Again, this is MSM exposure. In 2009, they became the leading exposure category for all new infections. And in 2011, they became over 50%. They have stayed that way for the past few years. I want to really quick talk about STIs and HIV and how they are overlapping epidemics. This graph just shows primary, secondary syphilis rates over the past 5 years, from 2010 to 2014. You can see in the red is MSM. In the blue is men who have sex with women, and the green is females. And as you can see, who are the ones bearing the brunt of primary syphilis infections? It's MSM. And we see in Maryland a lot of people getting co-infected with syphilis and HIV at the same time. For example, in 2012 alone, about 63% of all primary and secondary cases of syphilis also were infected with HIV at the time of their diagnosis. So when we talk about HIV, we would be doing a disservice if we didn't mention STIs to the conversation. And so, as you can see, the overlapping epidemics really follow three different levels: one from biological, one from individual, one from population. Of course, biologically, STIs increase HIV infectivity and vice versa through the breaking down of mucosal membranes, and increasing target cells and sites of infection. Individual level, you have overlapping risk behaviors like inconsistent condom use, sex partners. On a population level, we see increased exposure of STIs and HIV due to shared sexual networks, particularly among African American sex men, social factors like lack of access to care, poverty, housing, stability, income, and also stigma and discrimination. So they really go hand in hand a lot of the time. So all of these factors really tied into the needs assessment that we had in Maryland. This was conducted by our agency, the members of our the then MSM response team, who I hope is watching as their meeting is actually happening right at this moment. But the needs assessment that they came up with is called Combating the HIV Epidemic Among Same-Gender-Loving Men Who Have Sex with Men, HIV Prevention Among, Same-Gender-Loving Men, MSM, HIV Prevention Among MSM Who Have Sex. You know, I can see. All right. We got a little tongue-tied there. But anyway, so it was a summary of factors from epidemiological, from behavioral, all kinds of factors attributing to high rates of HIV infection among MSM in Maryland. It also was a study that we did, it was an assets and resilience survey. So it looked at what were those self-protective factors that MSM did to really keep them from, keeping them healthy and keeping them HIV negative. And out of all of this, it came up with 24 recommendations to address the epidemic. I won't go over all of them, but some of them include improving links to care among providers, expand the availability of proven HIV prevention interventions, like 3B. There's all sorts of ones out there. Increasing opportunities for MSM to develop, implement, and evaluate programs in the community. So really building MSM up into leadership roles in our community so that they can more adequately and more powerfully take control of the epidemic in their community. So problem statement, as we've seen in the statistics I've shown. So African American MSM continue to be disproportionately impacted by HIV in Maryland, and there are a few services statewide that target MSM specifically. Although we have all of our health departments provide HIV testing, we have a really good partner services program. We have a lot of things that are happening in Maryland. However, there are a few programs that really target this population specifically. If they are there, their reach is oftentimes localized and not as extensive as it needs to be. So we need to foster collaborations with traditional Black institutions to address stigma and lack of access to available prevention services and for sexual minorities. And that's really what led to me wanting to be a part of AAHU, was kind of figuring out how do I better mobilize the community where I live to address the HIV epidemic among this population. So we're going to now talk about my little journey through AAHU. Okay? So I'm going to real quick go through these, but these was some pictures from our AAHU Training 1, which is a month-long training here at UCLA. And we went through 4 different modules: basic science, clinical, epidemiology, and prevention. For me, I think some of the topics that I got the most out of was from the HIV life cycle. And it sounds small, but when you really have an understanding of how HIV replicates, it really opens up the doors of your understanding to all kinds of different topics, all from HIV disease progression, some of the cure research that's out there, pre-exposure prophylaxis. I think I'm an expert now. I'm talking about PrEP now. I don't know everything, but I can really now more adequately talk to people about PrEP and also about HIV treatment, talk about the different classes of drugs and how they intervene on different parts of the life cycle to keep people healthy. So from there, we went to our internship 1 period, which is my first one-day module presentation. I did a kind of a modified HIV 101 with my administration. About 35 people were trained, and I combined modules from the basic science, prevention, and treatment modules into one presentation. Again, I said 35 people were trained, and I thought it went pretty well. People came up to me afterwards and said that they learned something that they didn't know, which was surprising since some of these people have been working in HIV much longer than I have. So it was great to actually have given this information to individuals and they got something out of it. And that was evidenced in pre and post tests that were given. So around, I think 55% of individuals scored positively pre-test, then that shot up to 90% at post-test. So I felt really good about that. Since then, I've actually given the same presentation at a couple different venues, including training some of our substance abuse and behavioral health specialists for a grant that we have from SAMHSA, which is great, getting them on board about what's HIV and how it works and how it's treated and prevented. Also been asked to do the same presentation for a law firm that deals in HIV, so they want to make sure that all their lawyers are really up to speed with HIV and all the things that go along with it. So I'm excited that this presentation is actually having life outside of this actual program. Then we go to training 2, which is actually at BAI. It was a week-long training where we went through program planning. We got a quick and dirty about logic models, talked about social determinants of health and health inequities, theoretical frameworks programs, and then the steps for planning and main programs, and also evaluation methods. For me, the last 2 bullets is really what I got the most out of, the actual how-to of planning a program and how to evaluate it. It's been my experience through working in this field that I've seen a lot of programs come and go, and they've had the best intentions. However, they've not been planned properly from start to finish, and oftentimes they end up failing. So for me, just kind of getting the steps of really what you do in the beginning, how do you monitor it, and what do you do at the end, really helped me in the production of my internship 2 activities. So as I talked about, we want to engage traditional Black institutions to more adequately serve sexual minorities, including MSM. And my partner and I at the time, we wanted to do something with our local churches, because again, they are traditional Black institution. They have a lot of influence and power in our communities. However, they're not as active in our community as we would like. There are certainly those who do a lot, again, but their reach oftentimes not as expansive as we would like. So we came up with the idea of holding a couple different one-day workshops that we had around National Black HIV/AIDS Awareness Day. We geared it towards faith leaders. This is just one of the flyers that we had. We did 2 trainings, one in Baltimore City with Mount Lebanon Baptist Church, also in Hyattsville, Maryland, which is down in Prince George's County, which borders District of Columbia. That was the first time at this church. And here is an infographic from this presentation. So you can see that there was a whole lot of different topics that were discussed. BTAN Baltimore was really great in helping to get the logistics together. They also helped with the staffing of the event, from either stepping in and presenting or coming in and doing some breakout sessions, also helping with the funding for food, logistics. Also, my administration was really good at helping step in to do some of the presentations. So there really was a collaborative effort in that respect. From that, you see some of the topics that we talked about, and we really wanted to make sure that we talked about increasing people's capacity to know about HIV basic science. We wanted to see a 30% increase from pre and post test. Also, we hope to see a more concerted effort from those who were in the room to actually engage in sexual health conversations, to talk about HIV outside of the room and in their communities of faith. If you see these 4 little, what I call these lifesavers up here, this just talks about what people's own perceptions of the knowledge that they gain from the program when it comes to sexual health. also the knowledge about HIV, and also their likelihood to have sexual health conversations with their communities of faith. And overwhelmingly, people responded positively. Most people said strongly we agree that they got a lot out of it, and they wanted to continue on with those conversations. 30% increase in knowledge from pre and post tests. We got about 26% increase, which is about 89% to target goal, which I still consider a success. Wasn't too far off from what we wanted to see, so that was great. However, we only saw 19% of faith leaders present at our workshop. I think we were a little bit hoping that we would build this great thing, kind of like this build of dreams thing. Like if you build it, they will come. If you just build a program, and all of a sudden we'll see people flooding through the doors. That's not exactly what we got. Again, only 19% of those who were in attendance represented faith communities. That was something that our people who were there recognized and said we want to see more outreach to these communities of faith in order to make programs like this more successful and make sure that they get to people that need to be there. Going into training 3, here's our community mobilization module that we just finished about 2 months ago. Talked about coalition building, logic model, we expanded, and also started talking about our BTAN project proposals. I got a lot out of the logic modeling, except really kind of laying everything out in one sheet of paper from, again, what's all needed from inputs, the activities that's needed, and some of the short, medium, and long-term outcomes we wanted to see, which I'll share with you later on in this slide set. Okay, let's talk a little bit about BTAN Baltimore. It was established in 2014, actually following the completion of our first Baltimore AAHU graduate, Jamal Haley. The host agency of BTAN Baltimore is Star Trek. And since then, they've established partnerships that you can see in this graph, and done several trainings, including trainings with providers about the treatment needs of trans women of color, talking about the risks associated with MSM and interpartner violence, also the HIV risk among incarcerated individuals entering society. They've engaged with traditional Black institutions like barbershops, some of our, HBCUs like Morgan and Compton State. We work with a lot of the local clinics in Baltimore, like Chicks Brexton, Life Health and Wellness, and some of our local health departments with the state, and also with the Baltimore City Health Department. And as you can see, these are the project areas that each of those partnerships have focused in, whether it be treatment education, advocacy, exposure, or patient navigation. We are still trying to increase our membership, still trying to engage traditional vaccine institutions, and still very hard because of the stigma associated with HIV, particularly in our community. We know it's been around for a while. We still have that to fight with our traditional Black institutions. So let's talk about my BTAN project proposal. So we saw the success of the workshops that came out of internship 2, and people wanted to see more of that. And I talked with Jamal about the possibility of expanding this in and around Maryland. So that's the proposal that I want to see is expanding this National Black HIV/AIDS Awareness Day Faith Leaders Workshop in all parts of Maryland. And this really ties into the treatment education portion of BTAN really well. Some of the goals are similar to the ones with that workshop. So we want to see increases in HIV basic science knowledge, want to see less stigma when it comes to addressing sexual minorities and sexuality in communities of faith. And some of the objectives that we want to see, again, increasing HIV knowledge by 30%, reducing HIV-related stigma, and also just increasing the capacity of communities of faith to address these populations, whether it's linking somebody to care who may come in to their congregation, or just talk to them more knowledge about HIV and the risk about it. So these are our available resources from the Black AIDS Institute to some of our BTAN Baltimore partner organizations. Our Maryland Prevention and Health Promotion Administration is also a resource. We have the privilege, and we're really honored that we have this Center for Faith-Based and Community Partnerships that's headed by Carmen Washington Flood, which was really for us going into internship 2, trying to plan the workshops, really integral in helping us kind of direct the actual tone of the whole workshop, because when we you do HIV in the communities of faith, it can be a really touchy subject. So she really was great in just kind of steering us away from things that may lead to, pushback from the community. So she was great in that respect. And we really want to see her do more with this BTAN project proposal, whether it's linking us to some of our community partners or just helping us in the overall implementation of it. Also, we have our Center for HIV Prevention and Health Services that can provide information on HIV testing, capacity building assistance, so forth. We have our Maryland faith-based HIV testing programs and community-based organizations that serve African Americans, sexual minorities. So that's anywhere from Sisters Together in Richmond, which is STAR, which is in Baltimore. We have down in Fredericksburg County, Us Helping Us, which is actually out of DC. They do outreach services in Fredericksburg County. We have Heart to Hand, which is a great organization in Fredericksburg County. We also want to reach out to Balm and Gilead, which is a national organization out of Virginia, and see what information they can give us about best practices of engaging communities of faith, because they've done extensive work around the country. And we want to see what knowledge they can impart on us about how to accurately engage communities of faith. And then we'll also look at existing faith-based HIV prevention interventions, and also anti-stigma interventions. Just some initial kind of Google searching that I did, and I already found 2 that were out there, which is out of University of Alabama, and Your Blessed Health, which is out of Michigan. Even though we put on a great program, we want to see what's actually out there to see what kind of evidence-based interventions really address what we want to see, because, hey, it will exist, why recreate it? So we want to see, what things that we can possibly use to develop a program that we want to see here. All right, so implementing the project. So we're going to do identify our community stakeholders representing our population. We can start off with those who were actually present at our workshops and see who they know or would they like to be a part of the whole formal process. We're going to do our literature review of those faith-based curriculum. Then from there, we'll draft our first Maryland-based program that we'll take to our focus groups that we'll have with some of our Maryland faith-based stakeholders and also with African Americans. It's important that whatever we make is that it really resonates well with people in our community. Because let's say something that may work here in California may have nothing to do with people living on the East Coast. So we want to make sure that really reflects well with those individuals here in Maryland. From there, we'll do any revisions that we need to make, and then we'll start the recruitment process of our faith-based community members into the program. We were a bit overzealous in wanting 150 people at our 2 workshops. Again, we only got maybe a third of that between the 2. So for this next set of workshops, we want to make sure that it's kept small and more intimate, and really focus on having faith-based leaders there in the workshop so that it allows for more intimate and honest conversations about HIV and sexuality and sexual health. So we want to implement 5 workshops over the course of 6 months. And then there we'll do in-depth interviews with those faith leaders who attended during separate months following the implementation of the workshop, and also interviewing those actually in their congregation to see, how these conversations taking place. What's your the environment like now that your pastors or your faith leaders have gone to this workshop? Real quickly, let's go over some of the expected outcomes. So immediately following the workshop, we expect to see increased HIV health literacy, increased awareness of sexual health, increased awareness of specific health needs of sexual minorities, including MSM, and also increased awareness of the impact of HIV in our Black communities. HIV is here, it's not going anywhere anytime soon, and it's really up to our faith communities to really take a more vested interest and more responsibility in HIV that's happening in their communities. So our intermediate outcomes, so 6 months to 2 years following this, what we hope to see is decreased stigma of sexual behaviors often associated with sexual minorities. We want to see established coalitions of faith-based communities really taking active hold of HIV in the state of Maryland. We want to see improved relationships between our communities of faith and our public health entities, from the state health department, from our local health departments, community organizations, also increased involvement of communities of faith in BTAN activities. We saw this as a great avenue to increase BTAN membership. Over half of the people who attended our workshop said, hey, I want to become a member of BTAN after they heard about it. So a lot of people still don't know about it. So we want to see that these workshops, they also become part of BTAN and really help promote the goals and the vision of our chapter. And then here are the mountaintop outcomes, the long-term outcomes. So we want to see a sustained coalition between these communities of faith. We want to see increased views of communities of faith as being the leaders in our communities against the fight against HIV, which will ultimately decrease HIV infections in regions heavily impacted by the virus among sexual minorities. So this is my vision, this is my goal for this program, and I hope that we'll be able to get there. So going over some next steps, we want to get our formative research going and for a project implementation, including finding funding to put these focus groups and finding funding for the actual program itself and getting our stakeholders involved, identify who are those key people in our community that actually have influence, so we can get them into the focus groups and get things rolling. We want to now transition our co-chairs into leadership roles. Right now, we're in a place of transition among our chapter. Jamal Haley, which is our co-chair, is actually transitioning out of the role. So we're in the process of getting somebody else new into the position, so getting them actively on board, as well as getting all the co-chairs for all the project areas. They're committed, something that we need to have in order to promote BTAN and also this project. We want to see increased BTAN membership. Again, once we get those leadership roles in play, we want to get BTAN up and rolling and make it a much more stronger force. And also expand BTAN in the entire state. I'm talking about BTAN Baltimore. We would be really wrong if we didn't talk about the HIV that's happening down in Prince County that borders DC, or also Montgomery County. We want to make sure that BTAN is a statewide effort. So whether that be making BTAN Baltimore BTAN Maryland or making BTAN Maryland a separate entity, we want to make sure that BTAN really is expansive throughout the entire state. I want to involve my administration more in BTAN development, even though they were really helpful in the process of getting this project of my interested two workshops together. We want to see them be a more active force in BTAN from a government perspective. Right now, I'm the government co-chair for BTAN, so I definitely want to see the government behind me definitely be more supportive in BTAN. And finally, let's talk about me and my own personal experience. So I had a lot of successes in this program, from anywhere from my increased knowledge of HIV health literacy and science literacy. It was interesting when I got back in Maryland after the first long month. I had somebody call me, was a good friend who was like petrified of HIV. And I started talking about him about PrEP. And he was like, what is PrEP? And I was like, this is what PrEP is. And I'm like, you must have been a plant to kind of test me about what PrEP was. And I feel a lot more confident in my ability to actually talk about HIV in communities and presentations like this among my friends as well. And also improve my skills about program planning, monitoring, and evaluation. I can tell you there's some things I've tried doing in the past that have gone way downhill, so I'm more adequately prepared to do programming more effectively. And some of the challenges that I faced, a lot of transitions that have happened throughout the fellowship. For those who don't know, in my cohort, we started off with 3, as you can see, there's only 1 left. So really trying to divvy up the work between 3 people. Now just 1 person has been a bit of a struggle at times, but something that I've been up to the task. As well as, again, I talked about BTAN. So would I do it all over again? Absolutely, because I feel that programs like this really have helped me tremendously in being able to do the work that I do. And I hope and I know that this will follow me throughout the rest of my career. So I'm thankful for this experience. I'm thankful for Black AIDS Institute, also my administration, also Star Trek and BTAN. There it is. Take some final questions.
question.
Yes.
So when you talked about like the communities of faith that kind of training that you did, you mentioned there were about 150 faith leaders
that we wanted to get.
So you specifically identified those leaders.
Well, so we wanted to get, between the two workshops, we wanted to shoot for 150 total in attendance, with about half of those representing communities of faith. So 75 per workshop. We only got about 50 people per workshop. So those people were those who, like, they gave us their contact information so that we can contact them afterwards and say, like, hey, if you want to join BTAN or want to be part of this, we can do that with you. We wanted the 150, got nowhere near that. But again, we got a good starting base. And there were those who wanted to be attended that, of course, couldn't be. Whenever you deal with this community, you have to be really mindful of scheduling, because we can't have anything close to Sunday, because again, people are getting ready for church the next day. And we had our workshops on Saturdays, which was like the best option, but again, people have all kinds of engagements. So really, those are the things that we see as lessons learned about, okay, how do we go around that? So if we schedule a program, how do we get more people involved?
Okay, so like my specific question is like, so the 150, is that like an arbitrary number?
That was some arbitrary, like,
okay.
Like big dream, like, because we wanted to see like a big room full of people again. That was just something that.
So is there like a lot of faith? That's a lot for Baltimore. Like, was there a needs assessment that you looked at, or you just?
Yeah, I think it was just, again, something that I didn't plan well in that process. Okay. Again, I was just some arbitrary number that I came up with. Again, lesson learned. So when I do the project proposal, it'd be great just to have maybe like 10 or 12 faith leaders in a room at one point. Again, that's more realistic, and also representing different points of view, points of faith. So that was definitely one of the things that I learned really quick. Like, that's not going to work. Just having some big arbitrary number that it floods of faith leaders are going to come in, especially if they don't know who I am, they don't know what BTAN is. We really have to build trust among this community. So I have to be more realistic going forward about what my expectations are in getting people in. So again, we want to make that more intimate process.
And I think just like for the future, I think it's important not necessarily to focus on the quantity, but the quality, right? So who are these popular opinion leaders? Exactly. Who are the ones that are actually going to make some changes in the churches and in the faith community? So that's just something to think about in the future.
Definitely.
Okay, great.
Any other questions? All right, well, thank you so much. And now I'm going to turn it over to my fellow Ohioan, Jaasiel. He's going to come and talk about BTAN Cincinnati. Okay, cool. Yes. Yeah. Pointer. This is.
Good morning, everybody.
Good
morning. My name is Jaasiel Chapman from the great city of Cincinnati, from the great state of Ohio. And I want to thank everyone for this experience. My friend Aaron set the bar high. My presentation is nothing like his. You did an awesome job, Aaron. Cincinnati currently does not have a BTAN chapter. We are in the process of starting one. So a lot of the information that I'll be giving today and presenting on today is what I see as a need for a BTAN chapter because of the HIV epidemic in the city of Cincinnati. Well, let me start off with this. How I came into AAHU. Last summer, I wanted to get into advocacy with HIV and AIDS. Walking to the only nonprofit, minority-run nonprofit in Cincinnati for weeks. And almost immediately the executive director, Ms. Harris, came to me and said, there's this program that the Black AIDS Institute is doing out in California. She'd like to be a part of it. I said, me, I always love a challenge. I said, absolutely. Sign me up. Little did I know what I was about to get myself into. But it's been a great journey, and this is where we are. So getting started. So again, Cincinnati. I'm going to talk about the state of AIDS in my community first. And I'm going to begin with talking about the 4 main counties in my city. And the first one is Hamilton County. So I know this is kind of, you can't really read it, but so up top, so this is diagnosis of HIV infection as of June 30th, 2015. So this data is taken from the end of 2014 to the middle of 2015, so 6-month period. So we have white, non-Hispanic up top, Black, African American, Hispanic, Latino, Asian Pacific, Islander, American Indian, Alaska Native. And you see, either we don't have the data for or the population is just not showing any data for that. But for white MSM, in that 6-month period, 23 individuals were contracted the HIV virus. Blacks, 44. Black MSM, I should say. So with female, there was 5 for the white and 12 for a Black female. So let me throw this in. So Cincinnati, the population of Cincinnati, the demographic of Cincinnati is basically 50-50, 50% white, 50% Black. So you see with the white MSM, with the white male, 23, Black men, 44, that Black men still carry the heaviest burden in the city of Cincinnati when it comes to HIV. On to the next county, Butler County. And this county is not that many African Americans in this county, as much as there are in Hamilton County. So with the white MSM, you see there are 6, Black 2, with a total with females, white females and white males, 11, Black men and Black females, 7. So you see, with the injection drug use, we have 3 for Black African Americans. A problem that we are seeing in our community currently, we are in such crippling heroin epidemic where in our county we are seeing upwards of, on average, 2 people dying from a heroin-based overdose on a daily basis. So these numbers have been growing, and our medical director has stated that if we don't get a handle on the heroin epidemic in our county, HIV rates will rise, which is very alarming. Claremont County doesn't have many of us at all, so our numbers really aren't there. But so white MSM 67, Black MSM 5. So even I think the population in Claremont County, when it comes to white and Black, it's not even 95% white, 5% Black. So even with a lot of African Americans not being in that population, we still see that they have 90% of the infection rates in that county. Next, Warren County. And Warren County is the same as Claremont County. There's not a lot of African Americans in that community. So we have the white MSM 60, Black MSM 11, with a total of 100 for white and men and women, and for Black men and women, 29. So next, I kind of talked about the demographic profile, and I really want to dig into the epidemiological profile and just show some maps and show where the epidemic is very, very targeted in the different counties. So, okay, here's a map of Ohio. This is my county right here, Hamilton County and Cincinnati. So the darker shades of red show where the epidemic is most targeted. So if you take notice, we have Cleveland right here, Columbus right here, Cincinnati right here. Those three cities have the largest population of African Americans. So as you see, that those three cities, African Americans still carry the heaviest burden of the HIV epidemic. So rates of persons newly diagnosed with HIV by county. My county's right here. So again, I just want to take note. Columbus, Cleveland. So in Ohio, still those three cities carry the heaviest burden of HIV. Rates of Black persons living with HIV diagnosis by county in Ohio. This is in 2012. So right here, my county right here, you see the darker shade of red. So we have a heavy burden. We carry a heavy burden in the African American community when it comes to the HIV epidemic, as shown in this chart right here. Rates of White persons living with an HIV diagnosis by county. So you see the vast difference by the color that, let me go back. So you see, this is 680 to 1,070. And these are Black persons. Right here, 95 to 129. So you see the vast difference, and you see who carries the heaviest burden in my county, in my city, from the HIV epidemic. Race of Hispanic, still they carry a large burden as well, larger than our white counterparts. And here you can see a side-by-side graph of the difference and the disparity that we face in our city, with us being right here, with Blacks right here, Whites right here. And clearly shows that there's a problem in the Black community when it comes to HIV and AIDS that we must address. Hispanic, same thing. Now, this was really alarming to me. The rates of persons aged 13 to 24 living with an HIV diagnosis in 2012. And my county, right here, we have the most in the state of Ohio, which is sad that we have so many young people being infected with a virus that is 100% preventable. So this is why I feel like we definitely need a BTAN chapter to address these issues so that we won't continue to have young people being infected with the virus, like I just said, is 100% preventable. Now you see it starts to grow when you go up in age. This is 25 to 34, with the three main cities, with the heaviest population of African Americans still having the most diagnoses. 35 to 44. And 45 to 40, you see the colors start to really come in because people are living longer with the virus, of course, because of heart and the advancement of medications and science. And 55 and older. And still, right here, we have the heaviest population. This is the rates of males living with HIV diagnosis. And you see we have over 548. Right here. Same, you'll still see the same three cities. Rates of females, my city, we're still higher than just about every other county and city in the state of Ohio. Now, I want to talk a little bit about the difference when it comes to poverty and HIV. With poverty rates on the right side versus living with HIV diagnosis on the left side. And as you see, South Central Ohio, there is a heavy population of individuals living in poverty. However, right here, there's basically none living with HIV, or they have not been diagnosed with the virus. However, my county, we have a low poverty rate, but we still have a very high HIV rate. So I think for me, that shows that just because we're living in poverty does not particularly relate to them contracting the HIV virus. High school education, same thing. They have a very low high school education. We have high, but yet you still see the HIV rates still high in the county, in the cities and the counties where there are more Black people. And well, okay, so let me make a special note. So in this area, it's mainly all white, all Caucasian. So it's very low population of African Americans. And with health insurance. So you have these individuals that don't have much health insurance. My city, however, no HIV rates, still HIV rates. So even the discrepancy and the disparity of individuals that have health insurance and don't does not translate into who is contracting HIV and who is not. So my target population, Black MSM, Black females, and intravenous drug users. So I want to talk about bootcamp training one. My topic that I chose was basic science. I chose basic science because I'm sort of a nerd and I love to learn. And the science of HIV was so interesting to me. And learning about the life cycle and how the virus works and replicates and things of that nature. And I just wanted to go out and spread that knowledge and teach that knowledge. So I did one program. So the success and challenges. The challenges are what made this program. So I talked about this after training one, that I have the unique pleasure of being ingratiated with a group of older pastors, many of them being MSM, and they are married to women. So after the first training, I went home. One of my pastor friends was having, without giving out too much information, a milestone birthday, one of those main birthdays. So he was having a birthday party, and I asked him, I knew he was having other pastors, MSM, that were coming to town for the party. I said, can I come and share the basic science of HIV? He said, sure. So I was able to go in and teach about the basic science of HIV. And then we got into the topic and conversation of PrEP. Many of them, well, actually, I think, if I recall correctly, the vast majority of them had no knowledge of PrEP whatsoever. So I was able to go in and teach them and tell them about PrEP as a tool to prevent HIV, as they're, are living as MSM, but still married to a woman, and having that cover or the extra protection that they could use just in case. And so when I say that the only challenge that I had was the group of individuals that I was presenting to. That was the only challenge. The success was that I was able to educate on a possibly life-saving tool. So BTAN Project. The problem I found in my community is, especially in the Black community, we know nothing of PrEP, absolutely nothing. So that I would like to address this problem by increasing the promotion of PrEP. And the objective of my program is to raise awareness about PrEP on as large a scale as possible. So, okay, did a PrEP tour. Miss Erica Lilquist was there. The PrEP tour in itself was extremely successful. I would have loved for more people to have attended, but we took what we could get and did what we did with it, and it was amazing. Erica's one of the panelists. And one thing that was funny to me was that half the individuals there, and we had one Black physician, and he had no knowledge of PrEP. So we were able to educate half of the individuals that were there on PrEP. And that's what I want to see more of. And I believe that is what is needed, especially in our community, is the increased knowledge on PrEP. Black America Sweetheart, Mr. Jaasiel Chapman. So the name of my program that I want to put together, I want to call it Preparing for an AIDS-Free Generation, with PrEP being the subject of choice. So preparing for an AIDS-free generation. So Jaasiel Chapman, Black America Sweetheart. What I want to do, I have a music background, performing background. That's what I came from, that's what I did. So I know how music affects individuals on a personal level and on a personal basis, and how music can change the mood, the mindset, whatever situation you're going through. You hear that right song, it can change everything. So with that being said, Jaasiel Chapman, young Black gay male, I feel like with my top 2 target populations, Black MSM and Black women, he would be able to attract those populations. And what I would like to do is have some type of concert to where he is either a special guest or, yeah, he would have to be a special guest. I talked to Rebecca and she said, you know, yeah, so to be more cost effective, we'll have him be a special guest, maybe do a question and answer session, maybe possibly sing a song. Well, but we would definitely have like a local band come and perform and have him there. And I believe that he would attract the population that I'm targeting. And again, Black MSM and Black females. And that would be the title, Preparing for the AIDS-Free Generation. And the whole goal of this would be to promote PrEP. And if I could go a step further, I would like to do it on a nationwide level and just take the tour on the road. Because I feel like with music, again, it affects everyone. It affects everyone differently, but it still affects everyone and it impacts everyone. So yes, that's what I have. So, like I said earlier, BTAN says we don't have a chapter yet. It's been quite difficult trying to get things together to start a chapter, but that is definitely in the works. For Carice, Ms. Harris, I think she's watching, and with the rest of the city, the health department, and things of that nature. So, program title, like I said, Preparing for the AIDS-Free Generation, target population, Black MSM, Black females, intravenous drug users. Purpose of the project, promote the benefits of PrEP. And our community does not know of PrEP and the benefits that it has. The project proposal plan falls directly in line with what was found to be the need in my city. A comprehensive plan to promote PrEP to at-risk populations. So monitoring progress. So initially, I feel like the way that, and the program that I want to do, and where it's not your typical type of program, and my main goal is just to educate at first on PrEP and just to allow people to gain knowledge on Truvada and the effects and the benefits of PrEP. So monitoring ticket sales would show how effective this initial program is, and to show that how many people were affected by the attendance of individuals there. So the higher the ticket sales, of course, the more people reach. And that's my goal, to reach as many people as possible. The resources that we use, of course, the agency that I'm with for Carice, the health department, local media, CBOs, Midwest AIDS Training and Education Center, Community Advisory Board, People of Color Wellness Alliance, ASOs, and infectious disease doctors. Successes in AAHU. So this has been one of my greatest joys and sorrows. It has been, it's been a great road. I have met some amazing people. I've learned a great deal. And I think from this experience, I have been able to go back home and not only be more involved in the fight against HIV and AIDS, but it has increased my knowledge to the point where now I am being called upon to join different organizations. Like I am on the HPTN HIV Prevention and Treatment Network, and I'm going to the national conference education training next month in June. So things like that, I have been able, Community Advisory Board, I've been asked to be a part of that. So from this experience in AAHU has afforded me to be able to go home and take the knowledge that I've gained from here and disseminate it to my community to help make my community the best it can be and to help stop spread the epidemic of HIV and AIDS. And I think that, yeah, that's me. That's Jaasiel. Any questions? Rebecca, looks like you have a question.
I do.
Yes.
So, so for the tour, or for the first, I guess, concert that you wanna put on, what are your thoughts around how to make that something that's sustainable, so that, say, people come to the concert, they learn all this information. Like, how do you keep them engaged in hopefully what becomes BTAN?
That's a great question. I think that having literature and individuals there from different organizations to be able to link them with and connect them to once they get there, and then sign people up, especially when individuals learn over prep and they may feel like, oh, no, this is something that I may need to look into. This might be something for me, and then have the individuals there that can, like, have even a doctor or say a doctor or somebody like that of that nature. Be able to be there to be able to set up an appointment, or I could do it myself and link them to the correct people. But I guess to really answer your question, just having all the resources and all the pieces together so that no one falls through the crack, and while we're preparing to promote crack. So, I don't know if this is okay. Yes, ma'am. Anybody else? Yes, ma'am. I have not. I have talked with different individuals, and I have not gotten any type of solid. Correct. I will say that there are some individuals in Dayton and Columbus that are interested in. So, but the problem lies where, distance and trying to schedule where it works for everyone, the time that works for everyone, and everyone can get together. So we're trying to work that out, and some way, somehow, we're gonna make that happen. Yeah, right. That's what I said. Right, it's a short drive. You can make it. You can come down, or I can come up. Yes, you're right. Exactly, because it needs to happen. So we're gonna make it happen. Anyone else?
So do you know what is the nearest BTAN to you? Like
Chicago.
Chicago would be the closest to you.
Yeah.
And how far is that?
4.5 hours.
See what they're doing and kind of learn.
Yeah. Yep. 4.5. Right. Now that we can't make happen on a regular basis. Not with the amount of people that we need for BTAN, but we're gonna make something happen, and we're going to make it successful and impactful for the community. Save the world. That's the goal. That's the goal. Save the world. Knock out HIV and AIDS for good. Anyone else? All right. Thank you so much.
I don't know.
Good morning. My name is Cheryl Davis, and I'm from Richmond, Virginia. I currently serve as one of 3 BTAN co-chairs for the Richmond-Petersburg BTAN chapter. I also serve as outreach coordinator for Community and Development Incorporated, also known as SID. The mission of SID is the social, economic, and educational empowerment of residents in the inner city, especially the east end of the city of Richmond. In 1995, I participated in the My One Word project, based on the book by Mike Ashcroft. The author encouraged readers to stop making New Year's resolutions, but rather focus on one word that would change your life. After following the steps in the book, my one word was revealed: greater. Greater means working where you are, doing good work where you are, while striving for greater. And that kind of sums up my experience in AAHU, my work in the field of HIV. Doing work now, but expecting greater. Donna?
Thank you, Cheryl. Good morning, everyone. My name is Donna Powell, and I come from the city of Fredericksburg, Virginia. I am currently the Prevention Program Services Manager for FAHAS, the Fredericksburg Area HIV/AIDS Support Services. I currently have a staff of about 4, and we go out to the community and disseminate HIV information, as well as doing rapid syphilis testing, rapid HIV testing, and in the very near future, hopefully hepatitis C testing as well. In 1996, my life changed. My very best friend was diagnosed with HIV, and I had no understanding. How? Why? He wasn't a gay white man. He was a gay black man who only had sex with black men. And from everything that I had been told during that time, this was unheard of, because it was only happening to gay white men. So I made it my mission that I had to find out all that I could about how to help him, how to be there for him, and let him know that even though he was going through this, I would still love him, I would still be there with him, and we would take this journey together. And thus my journey began. My journey of learning all that I could about HIV, so that I could not only help him, but to help others like him, to be that resource for them, to help them live a better life, a better quality of life. And that brought me to the field of HIV and AIDS, which I've been in now for 16 years. But it also allowed me the opportunity to be a part of AAHU, class of 2016. So that the information that I have gained throughout these 9 months, I could disseminate to my community, to my staff, so that therefore we could continue on this journey of making a difference. And so now Cheryl and I will continue this journey together and hope that you will take this journey along with us on a road to greater good. So the demographics, what we did here were we took the demographics of Virginia and compared them with the demographics in Fredericksburg as well as Richmond. Now Fredericksburg is about 58 miles north of Richmond. And there are some vast differences in the 2 cities. But, excuse me, as you can see, there are some similarities. Now, we know the site is a lot busy. There's a lot for you to take in. However, what we want you to see is how the city of Virginia, how the state of Virginia, excuse me, is comprised, as well as the different cities that we represent as well. 19.7% of the state of Virginia is African Americans. However, 21.4% reside in Fredericksburg, and an astounding 49.7% reside in Richmond. So we're talking about over half of the population just in those two cities. The income, 64%, 64,792 median income in the state. However, there's only 40,454 in Fredericksburg, and even less in Richmond, 41,331 in the African American community as well. The poverty level, 11.8 in the state, but we see a 16.8 in Fredericksburg and an astounding 26.7% in the city of Richmond. So those are some vast differences between the state and the cities alone that I think contribute to the epidemic that we're seeing with the rate of HIV infection across the state.
The epidemiological profile in Virginia as of 2014. Again, another busy profile, but that's intentional. We want to show you the overwhelming impact that HIV has in the state of Virginia. 25,690 persons living with HIV in Virginia, and of those, 15,279 are African Americans. That's 59%. 10,356 African American males are living with HIV in Virginia. And male-to-male sexual contact is the highest mode of transmission at 37%. And here you have other statistics within Virginia. 7,644 white living with HIV, 1,983 are Hispanic, 322 Asian, 33 American Indian, and then 409 are unknown race. And that's collectively from the data that we received.
Now this slide here shows the breakdown in age. As you can see, the 40 to 49 age group has the highest rate of positivity rate among those living with HIV. And what's amazing to me is that a lot of people tend to think that it is an epidemic that is affecting the younger generation. And clearly you can see this isn't. And as we've gone throughout this process, we have come to realize that more than 50% of those who are HIV positive are over the age of 50. And you can see that here with the 40 to 49, as well as the 50 to 54, and the 55 to 64. So this isn't an illness that's affecting the younger population, but it's older people alike. And it has a lot of contributing factors. One, people are living longer and they're staying healthier, being HIV. And I like to tell people that it's now affecting a population that years ago wouldn't have thought about HIV. They don't think about using condoms in the 50+ population because all they thought about at one point was procreating. And they know at that time, their chance of procreating had diminished. So now we have Viagra, Cialis, and all of these other little enhancers for the older population that continues to help them to be sexually active. But a lot of times we aren't thinking, and I say we because I'm falling into that category, but we aren't thinking about STIs. We're not thinking about HIV. Only thing that we thought about at one point was that we can't have kids anymore. We can't procreate. So now we have to get them into the mindset of thinking on a larger scale, and that scale being protecting yourself so that you don't fall into the category of being labeled as being HIV positive. Now, this is where we find a greater disproportionate number of men and women, as well as transmission modes. 1 in 4 men will become positive by the time they're 25. Wow, that's a lot. Because as African Americans, we only make up 17% of the population. But to think that 1 in 4 African American men who have sex with men will become positive by the age of 25 is a little unbearing, a little unsettling. And so therefore we have to find ways to make a difference. But not only that, 1 in 2 will become HIV positive by the time of 35. That means somewhere along the line, our message is being lost. So we need to find out new ways of getting the information out to our young Black men who are MSMs or same gender loving men so that we can decrease these numbers. And we need to start now. We need to continue on this journey.
In addition to the information that was found in our state's needs assessment, Donna and I had the opportunity to participate in a focus group with MS Virginia, Eastern Virginia, as well as Northern Virginia. And what we found out, we talked with the group about things that impact them, their take on HIV and what's being done regarding HIV in the state of Virginia. And we came away with 5 common themes that were lacking, and they're listed here. Mental health services and substance abuse services. A lot of times MSMs, whether HIV positive or not, they're dealing with stigma, stress, and other phobias, and they need, sometimes they address that with substance abuse, or they manifest in mental disorders. So there seems to be a void in the services that are available or linkage to care to those services. And then again, linkage to healthcare. There are a lot of services available in Virginia in terms of healthcare. We have the affordable healthcare. We have Medicaid, and we also have through the state health department, MMAP, which provides prescription assistance to those on disability, and also prescription assistance through the AIDS drug program. However, there's a gap between the care programs and people getting into that care. And then discussions of reducing stigma and other initiatives to just better the community. What can we do as a government, as community CBOs, as faith-based organizations to reduce the stigma surrounding HIV and AIDS? And we're going to talk a little bit more about that later on. And then discussions across social economic barriers. Not every MSM falls into the same category. So how do we reach people across the board? One of the strong comments that came out of our discussion when we referred to the group as MSM, one gentleman stood up and said, "I'm not an MSM. That describes what I do. That's not who I am. I'm a gay Black man." So we've got to figure out how to reach people across those lines. A brief overview of BTAN. The Fredericksburg chapter is still in the development stages. The Richmond-Petersburg chapter has made great strides in all 4 of the project areas that you see listed, there. Treatment and education, patient navigation, disclosure, and advocacy. Just to mention a few things that have taken place in Richmond and Petersburg, we have held several brown bag lunches, also training and testing events at Virginia Union University and Virginia State Universities, 2 premier historically Black colleges and universities in Virginia, and also at Transformation Expo. You know, if you're from the South, Transformation Expo is a huge deal. People come from all over the state to get information. We have dynamic speakers, national music artists, and we had BTAN Richmond Petersburg testing and providing education. Advocacy and patient navigation. We've been working really closely with Enroll Virginia to get persons linked to care through the affordable health care. Thus far in 2016, we have assisted 250 persons in getting into care. Disclosure project area, we're really proud of our progress in that area. We have identified 5 persons. Our goal was 4, but we reached 5 to establish a speakers bureau of HIV positive persons who are willing to go out and share their stories. And they participated in several forums, most notably Let's Talk Sex, Love, and Relationships. And we're having a powerful impact in Richmond, and we want to continue to do more in that area. And looking forward to bringing Fredericksburg on board as well. Our next steps, again, in Richmond, we want to continue to recruit additional members and also build new partnerships.
In Fredericksburg, as Cheryl said, we are still in the planning stage, the infancy stage of establishing the BTAN. But it is our hope that in the very near future, we will be one of the chapters coming under the Black AIDS Institute. We have formed several partnerships with the health department, the Infectious Disease Associates of Fredericksburg, who are our ID docs in the Fredericksburg area. We have had 3 or 4 churches who are very much interested in the work that we're doing. They were a part of our prep summit. They want to know how they can gain more information, how they can be a part of. So we're looking forward to those collaborations and continue to recruit people in the community, because there are a lot of community advocates out there who know a little bit about what we do and about BTAN, but they don't know enough. So we will continue to get the word out, continue to have forums, continue to invite people to the table so that they can understand what it is BTAN is, how it can help our area, and how we can better serve the community at large. Cheryl.
When we talk of this clicker is not my friend. When we talk about additional recruitment in Richmond and Petersburg, we have received, with the help from Black AIDS Institute, best practices in recruitment. So we're in the process of identifying a recruitment manager and then taking a look at some of those best practices so that we can get more members involved. In terms of building new partnerships, we're looking specifically right now at 2 partners. One is Fan Free Clinic. That's a powerful organization that provides health care to low-income community members. And then Rosemead of Richmond. Rosemead is a community organization for LGBTQ teens. And that's a powerful organization, giving them a safe place to discuss issues and learn. So we're really interested in building that partnership.
And to piggyback on what Cheryl said about Fan Free Clinic, Fan Free Clinic is one of the first clinics in the Richmond area who will be prescribing PrEP. So we're very, very proud of the work that they're doing and how it can assist us on a larger scale, not just in the Richmond and Fredericksburg area, but also in Fredericksburg. Because again, those cities are only 58 miles apart, so people are traveling to and fro on a regular basis, so that if we can partner with them so that they can assist those not only in the Richmond and Petersburg area, but as well as Fredericksburg and some of the other northwest cities. Ooh, I'm having a problem with the C's and S sounds. Northwest cities near Fredericksburg, so that everybody could benefit from PrEP. I think we will be doing an amazing justice and amazing work all the way across the board. And Cheryl and I are just going to continue to share what we've learned here at AAHU, as well as in our respective fields and in our respective positions, so that we can continue to carry out the message.
Speaking of sharing what we've learned, right after completing the 30-day boot camp, we were charged with going back into our communities and sharing what we learned. My first training was on the natural history of HIV and basic training, basic science. And I did that with the BTAN Richmond Petersburg group. There were 9 people in attendance, and there was a 28.9% increase on the post-test results. Interesting story about this training. As I mentioned, it was with the BTAN, with Richmond Petersburg BTAN chapter. There was a physician, there is a physician who's a member of our BTAN. So as I was presenting the information, he would often interject and share information. If another member asked a question, he would just step up and answer the question. So finally I said, okay, let's do this. I need to be able to share this information and feel comfortable with addressing questions. So if there's a question, let me address it first, and then you can add on. How about that? and he agreed. So the rest of the session went smoothly. I did notice on his evaluation, he indicated that he did not learn anything new, but he also gave me a comment that I presented the information in a great way. So I was pleased with that. Specific populations, one of the things that we were working on at the time in Richmond was preparing an RVA Day of Affirmation. And that consisted of churches in the area affirming the diversity of families in our communities. So we asked pastors to make a statement from the pulpit, lead the congregation in a litany, and also hold focus groups in their churches. So that planning committee, we felt needed, or I felt needed, some training on specific populations. So 7 persons attended that training, and there was a 47% increase on post-test. HIV prevention, that was done with the Richmond Redevelopment and Housing Authority. And that authority is basically our housing communities projects, for lack of a better term. There were 21 persons in attendance and a 30% increase on post-test. After I completed this training, a young woman came up to me and she said, "You mentioned something about PrEP. My husband is HIV positive, so I think I need to be on PrEP. How can I find out more information?" She shared with me the clinic that she was going to, and we were able to talk with a social worker in that area. And there were some specific reasons why that individual was not prescribed PrEP. But it was an amazing feeling to have a stranger come up to me, trust me with that information, and then I had the tools to assist her with walking her through that process and advocating for her. And I think that's really what AAHU is all about. Overview of science and research that was conducted with Virginia Union University faculty retreat. There were 9 attendees and a 28.9% increase on the post-test. And this presentation was actually sort of an interview. Every year, the School of Theology at Virginia Union University hosts a 4-day conference. Last year, we dealt with issues, sex in the city, dealing with the biology of sex in men and women. And of course, we dealt with some HIV issues. And that conference was coming up again December 2016. And I really wanted to be a presenter. So I felt that presenting to the faculty was an excellent opportunity to showcase my skills in that area. And Donna facilitated an overview of the boot camp for FAHAS, her agency. So she was able to collapse 30 days of information into a 4-hour session, an awesome feat. There were 21 persons in attendance and a 12% increase on post-test.
Which brings us to, as Cheryl was talking about PrEP, and a young lady that came up to her wanting to know information on PrEP. Fredericksburg, as well as Richmond, held their PrEP tours this year. Richmond, Petersburg in February, and FAHAS in April. And I have to say that I attended the Petersburg-Richmond PrEP tour, and I found it was phenomenal. It was very engaging. Everyone there seemed to be really engaged, had some really nice questions, and I think all of us left there feeling a little bit more empowered about how to disseminate PrEP information, as well as where to come or where to go if we had any other questions, and where to send people if they wanted to be a part of PrEP. Cheryl had 47 attendees. There was a 10% increase on post-test and 33% reported increase of knowledge. Fredericksburg, again, is a whole different entity within itself. And there isn't a lot of information on PrEP within that city. We only have one set of ID doctors in that city, and they themselves are not very knowledgeable about PrEP. So I found it very rewarding that I could come and be a part of this PrEP summit, well, to facilitate this PrEP summit with the help of Erica and a couple other people. So that we could get that information out there to them, let them know what was going on, give them information about PrEP, dispel some of the myths that they may have had about PrEP. And I think for it being the first one, I think it was a phenomenal job. We had 35 people in attendance, and 53% reported an increase in knowledge, and also wanting to gather more information. What I found really rewarding for me was the very next day I had one of our clergy to send me an email. And she said that she got a call that night from a friend of hers. And she was telling them all that she had learned about PrEP through this summer. And her friend said, wow, that's interesting, because I'm now on PrEP. And she was able to have a dialogue with that person and understand exactly what PrEP was and what they had to do and what they would be going through, and to share the information that she had gained. And so she sent me an email thanking me for allowing her to be a part of that process and wanting to know more. On our evaluations, a couple people indicated that they want to see more of this. They want to see more of this in the community. They want to see more of this with lay persons, because a lot of the people that we had at the table were service individuals, but they want to see PrEP on a larger scale. They want us to take this information to more community events so that more people can become involved, more people can become knowledgeable, and that way we can continue to make a difference. And I think that was the key thing that we gained out of this PrEP Summit, is people wanting to know more, people wanting to be more involved, and continue to get the information out there.
We talked about some formal trainings that we've had, but we've also had some opportunities for informal training. Just to share a little bit about myself, in the last 3 years, I have lost 6 close family members. The latest one at that time being in September, just after returning from boot camp. So I was really going through a hard time. My friends wanted to get me out of the rut. So we decided to go to a Scandal watch party, the premiere of Scandal and How to Get Away with Murder in September. So we went to TGI Fridays, sitting there in a bar full of people, having a good time, and one of the actors mentioned that he was on PrEP. And someone in the bar said, "What's PrEP?" Instinctively, I started to answer, but then someone else said, "Shh, story's coming on." So I thought, okay, nobody wants to hear this. But as soon as the commercial came on, people turned to me and said, "Okay, now what were you saying?" And you could actually hear a pin drop as I started to talk about PrEP. And I have been a project manager, or I was a project manager with the city of Richmond for 15 years, where I implemented multi-million-dollar projects. I had the opportunity to train before or provide presentations to governors and officials at all levels of government. But the training that I have done as a result of AAHU has been far more rewarding than any of those trainings that I have ever conducted. And I am so appreciative to the Black AIDS Institute for the opportunity. We're going to move into our project now, our proposed project for BTAN. And our target population is African American MSNs. And we're targeting this population because they're dealing with several issues, as you see outlined here. Faith and family, addictions, men on the down low, whether they want to use condoms or not, STIs, getting tested, and a multitude of issues. So we want to address that population. We also want to address the faith-based population. We noticed again in our focus groups, that was one of the things that the MSMs indicated. There's a gap between the faith institutions and our MSMs. The MSM populations feel that they're stereotyped by when they go to church. And then the faith population feel that they may be disrespected by the MSM population. So we need to address both of those communities and bring them together. We want to address families, particularly families with MSM members. And we also want to address the community at large, get the community involved in HIV prevention and reducing stigma.
And as Cheryl said about the faith-based organizations, being in the African American community, we know that faith-based institutions have always been the cornerstone of our communities. That's where we've always gone for prayer, for worship, for advice, just to feel inclusive. We went to church. If we ever went through a problem, our forefathers or our grandparents would say, well, take it to God in prayer, take it to the church, take it to the pastor. So we're finding, as Cheryl said, the disconnect with the MSM community and being able to do that. So we're trying to find ways and how we can remove that disconnect, how we can bridge that gap so that MSMs alike can still feel comfortable with being who they are and being able to embrace their faith and being able to have that relationship with our faith-based organizations. So, as you can see, these are a lot of the things, these are a few of the things that our young MSMs, our Black MSMs are dealing with: stigma, discrimination, homophobia, and violence, and so forth. So therefore, a lot of times they suffer in silence because they don't want to deal with these things. So they remove themselves a lot of times from the very things that they should be embracing, the very people who should be embracing them, and that one being their families as well as faith-based institutions. So, as Cheryl said, we're now going to talk about our project proposal. And these are our goals and objectives. One is to develop a media campaign titled Bridging the Gap, to encourage greater sensitivity and less negative opinion of persons with different sexual orientations in the faith-based organizations as well as communities. We need to find a way to get the message out that they are still a part of, that they are inclusive. Remove that stigma that is associated with same-gender loving persons. Remove the stigma that they are no longer embraced into a faith-based institution, that they are no longer embraced into their own community. But finding a way to let them know that we're here for them, we'll always be here for them. And so we need to, we're gonna figure out a way how to get this media campaign out. And I think Cheryl and I have come up with an excellent way of how to do that.
Donna has shared our overarching goal for the project, to start a media campaign with families with MSM members. We're all familiar with Miss Mary, who sits on that second row every Sunday. She always has a mint or a piece of candy for the kids. She gives you $1 when you come home from college. Well, Miss Mary's grandson is gay, and Miss Mary loves her grandson, and you love Miss Mary. So just imagine seeing a picture of Miss Mary with her gay grandson and a capture, "This is my grandson. I love him. He happens to be gay." And the key message there is the love. The fact that he's gay is secondary. And our churches should be about love. Our communities should be about love. So that's what we aim to portray through our media campaign. The specific goals or objectives in our campaign, we want to reach at least 50 churches who will agree to participate in Bridging the Gap. And we want them to participate by, one, helping us to recruit families in their congregations, and also agreeing to post collages of the pictures that we develop in their churches. Not in the back room, not in the closet, but in a prominent place in their church. 100% of the church, we want 100% of those churches to agree to place those pictures. And we want at least 2,500 people to see the display of families. And we realize that's a big goal, but this is a big problem. So we have big goals and we want to attack it. And we want at least 25 MSM families to participate in Bridging the Gap by participating in the photo opportunity. Now, to go into some detail on our project, our inputs. Our inputs are also our partners. Black MSMs, that's our target population, and we want them to participate in the campaign, and we also hope that they benefit from seeing the campaign. Social media manager, that's a human resource to provide technical assistance, assisting us with getting the collages done, getting ads placed on those social media spots. And when we talk about social media, we want to use Facebook, we want to use Twitter. We also want to put advertisements on applications such as Grindr, Jack, those kind of things. The Virginia Department of Health is a sponsor. It's a government agency, and it's also a potential funding source. As I mentioned earlier, the focus group that we participated in was hosted by the Virginia Department of Health. So they realized the issue, capitalized on what they've already realized. The Richmond City Health District, Petersburg Health District, and Fredericksburg Health District. We're looking to them for assistance with education and collaboration. We want to use them again to help us post the collages and other advertisements that we come up with. And we also want to use them for recruitment as well. The Help Center at Minority Health Center. That's a community-based organization that focuses on the MSM population. They provide free testing, condom distribution, and they also host once a night, a Wednesday night kind of chat session. It's a place where MSM can come and just gather on a Wednesday night. They may have movies, it may be a discussion regarding something in our community, but it's an awesome gathering and they have a great forum. Rosemead, which is the youth LGBT organization. That's a partner that we want to use for recruitment as well. And the Diversity Center of Richmond is another community-based organization that we want to utilize for support and recruitment. And then faith-based organizations. We need them again to participate in the media campaign as well as recruit members or families. Our activities, what will we do to get this project going? We want to reach out to the MSM communities, ask them to talk to their family members, see if they're willing to participate in the campaign. We want to reach out to faith-based institutions, get their participation and their buy-in in participating, and also recruit family members. And we also want our faith-based organizations to host photo shoots. We'll need to recruit a photographer to take the pictures. We'll need someone to develop a collage of all the different families. And then we need that social media manager that I mentioned earlier to help put our campaign together. Place those ads in various places. How many times have you tried to play a game on your phone and an advertisement pops up? Well, we want Bridging the Gap to be that advertisement.
Now, in order to do that, we have to set some guidelines. We have to do some evaluations, so to speak. So Cheryl and I decided that we would do some process evaluations as well as outcome evaluations. And with the process evaluations, what we thought about doing were interviewing the families, saying how comfortable they are with participating, because we know a lot of times people don't want their business out there. They don't want to address the fact that they have a gay family member, let alone be able to have a photo taken and to have that photo publicly displayed. So we want to be able to interview these people, let them know the importance of it and how it's coming from a place of love, a place of embracement, a place of, again, bridging that gap that has occurred because of their lifestyle. Also, we thought about, what we intend to do is to have them to create a diary that they would journal their feelings and what they experienced going through this process so that they can become in tune with what they're dealing with. And I think a lot of times it's better when we write it down and we see it on paper and we can go back and reflect. Okay, talking about this made me feel this way. Talking about that helped me to become a little bit more relaxed or release that pent up negativity that I was dealing with because of the situation. Also, we're going to go out and have these focus groups, have these talking points or presentations, so to speak, with our faith-based communities, with our health departments, with the community at large, so we can continue to get that information out there, get that feedback from them as well, so that we will know whether or not we're on the right track and whether or not we need to make some changes, whether or not we need to deviate from one thing to another, be more inclusive of something and remove something else. So getting that community feedback will allow us to make sure that what we're trying to do, we're on target with. Outcome evaluation, a survey at the end. find out how this works for them. Would they like to see this on an ongoing basis? If not, maybe a yearly thing, an annual thing. So get the feedback from the community of how this actually works for them, so that we'll know that on our next journey, because this is a never-ending journey for us. This road will continue until we reach our goal. We'll know what to do better the next time.
And when we talk about outcome evaluation, we're looking at short-term outcomes. First, greater awareness of HIV and an awareness and acceptance that stigma actually exists. Long-term, we're looking for reduced stigma and discrimination among MSMs, and we're also looking for decreased HIV infections among MSMs.
That is the key point. Reducing the rate of infection in our communities and in our state at large. So, our AAHU fellowship experience. Woo! This was the green light. These were the things that we thoroughly enjoyed. The HIV science and treatment literacy, forming the new relationships that we have with all of our AAHU cohorts, the networking opportunities that it has given us, because we've been able to network with some people that normally we wouldn't be able to meet on a regular basis. And then the additional BTAN resources.
And again, I mentioned my greatest success, that rewarding experience that I gained through training, the training that I've been able to provide, both the formal and the informal training.
Managing multiple responsibilities, because being a part of AAHU is a huge responsibility. And we've had to be able to incorporate that responsibility into our daily lives, as well as into our work environment. And the frequent travel miles. Ooh, going from East Coast to West Coast, and the expense that it entails at times can be a bit challenging. And then full disclosure prior to the training, because we had to tell who we are, what we do. And so it was a bit challenging at times. And then the graduate fellows involved in the boot camp. So with that, we thank you for listening to us. And are there any questions? No questions? Oh, yes.
First, I love the idea of that campaign. Now, with the individuals in the separate in the specific churches, will the photographs be of actual members of that specific church?
That is our intent.
Okay.
Members of that congregation, a part of the program. So it won't be First Baptist A&M displayed at St. Paul's.
Okay.
But it will be congregation members of St. Paul's being displayed in St. Paul's.
And then the second level of that will be a collage of all of the families across all of the faith-based organizations. So you may see one giant collage in a church with family members from all of the organizations.
And we can rotate that collage on an ongoing basis.
And the advertisements that we hope to develop will definitely consist of all of them.
Again, we thank you.
Thank you.
Don't go back.
All right, good morning. My name is Yolanda Price. I am a BTAN Melbourne Community Co-Chair. I am also a 2016 AAHU Fellow. I got involved in this arena by helping out my cousin, which is John Curry, which he was a former AAHU. Actually, he's a graduate. I'm not sure what year, 2012. Anyway, I got involved helping him form a BTAN in our city because we didn't have one. And so it was just natural that I got into it because I am currently going to the University of Central Florida and obtaining my bachelor's degree in public administration. But my minor was in volunteer management, so it was just natural that when I got involved with helping him, that it was just part of what I was doing already. Once I started volunteering with him, I realized that the information wasn't being forwarded to women, like the lack of information, because the focus, the national initiative focuses on MSM, and I felt like the women was being left out. So me being a woman, I figured that I could be the voice in letting women know that they need to take care of their total health. So that's what got me more involved in it. And then it came up with the application, so I submitted, and then I got accepted, and so I'm here. I have learned a lot, and my sister organization, BTAN Broward and Krystle, introduce her.
Good morning and good afternoon for our visitors who's visiting us via web. My name is Krystle Mobley. I am the Minority AIDS Coordinator for the Florida Department of Health in Broward County. I am also the government co-chair for BTAN Broward. And as Yolanda mentioned, we both equally do this work to educate and empower the Black community on the importance of knowing their status, and if they are positive, to seek treatment in order to live a longer and healthier life. That's our mission. And all of the work that we do through our individual chapters is to educate and empower the Black community on knowing their status and seeking treatment if you are positive. So we'll jump right in. To give you an overview of our presentation today, we will be giving local data on our individual counties and then discussing it as a whole for the state of Florida. The state of AIDS in our community in Broward County. Fort Lauderdale is a county located in the state of Florida. The Fort Lauderdale area is in the county seat of Broward County. Broward County is Florida's second largest metropolitan area. It is a majority county demonstrated by its 2013 population. By race, Broward County has a diverse racial and ethnic population. HIV in Broward County is widespread and unfortunately uncontrollable. Broward County is consistently ranked in the 2 to 3rd position nationally for newly diagnosed HIV cases. We have a total of 18,039 persons living with the diagnosis of HIV infection in Broward County through 2014. And people of color and men who have sex with men of all races and ethnicities continue to have a disproportionate impact when it comes to HIV. So before we bring up Yolanda to discuss the data in her county, we just want to give you an overview of the epidemiology that we're going to be using today. And it is provided by the HIV/AIDS surveillance program for the Florida Department of Health. And this program plays a vital role in how Florida determines HIV/AIDS resource needs, allocation methodologies, and program planning. The goal is to collect complete and accurate data and analyze the trends in the HIV/AIDS program and HIV/AIDS. The program staff and the county partners utilize this data to plan, carry out, and evaluate HIV/AIDS programs and intervention. So all of the data that we're going to show you today comes from the Florida Department of Health. So continuing with the adult HIV and AIDS cases reported in 20 on the population partnership area 10, which this is the Broward County area. And it shows that in this snapshot for 2014, Blacks are overrepresented among the HIV and AIDS cases, accounting for 42% of the adult HIV/AIDS cases and 61% of adult AIDS cases, but only 25% of the adult population. A group is disproportionately impacted to the extent that the percentages of cases exceeds the percentages And this slide clearly shows that.
The state of AIDS in Melbourne, Brevard County, is located between Miami and Jacksonville. We sit in the middle of the east coast. We're like 35 miles from Orlando, so we're considered as the Florida Space Coast. We offer like 72 miles of unique beaches and coastal areas, and people come to visit. We're also known as being the home to Kennedy Space Center. I know all of us know about the space shuttle going off. So that's my home, Cocoa Beach, the famous Cocoa Beach area. And the Port Canaveral, where we have a lot of cargo going out. Actually, we're being known nationally because we're using a lot of cargo out of the Port Canaveral area. In Brevard County, we have a total of 1,473 people that's being diagnosed with HIV and AIDS, which 36% of that diagnosis in the 2014 data was Black. In this county, according to the 2014 census, there is only 556,885 people. The white population accounts for 83.8% of that. The Black population only accounts for 10.7%. And mind you, again, 36% of the HIV and AIDS cases is Black, so that's a big amount of people. In a snapshot for the 2014, again, we're overrepresented among HIV and AIDS cases, accounting for 34% of the adult HIV cases, and then 45% of the AIDS cases. But we only represent 14% of the adult population. Again, we are disproportionately impacted, and the percentages of the case that sees the percentage of the population. So the summary of the key needs assessment findings that shaped our project proposal. In the state of Florida, the data collected for the epidemiology of HIV infection trends in Florida diagnosed through the 2014 report, and the state of needs assessment gives a sketch of how social determinants in life are contributing factors to the disproportionate impact HIV is having on minority communities. People of color and men who have sex with men of all races and ethnicities continue to be disproportionately affected by HIV and AIDS in Florida. There are a lot of health disparities and barriers to HIV prevention and care, such as poverty, housing, and instability, substance abuse, and stigma. The needs assessment narrative illustrates a detailed picture of how the lack of employment and housing is the largest barrier affecting minorities. According to the assessment findings, respondents, which is the number is 5,901, reported that 55% were not working, and 20% were working full-time, and 11% working part-time, and 8% was off and on, and 5% was self-employed. With the largest portion of the respondents not being employed, it does not place healthcare as a high priority. In addition, in the state of Florida, 13% indicated depression as a barrier, and a sizable proportion of those needing mental health services did not receive them.
So to jump in, to show you the demographic profile on everything that Yolanda just presented to you, just to show you how our total population in the state of Florida is. So we have a little over 18, and if you notice, when we go to the male-female, 48.9% of the population is male, 51.1% are female, and then it shows that 16% of the population are Black, 75% is white alone. We have 0.4% American Indian, Alaska Native, 2.4% Asian, 0.1 Hawaiian Pacific Islander. And then if you go down, if we drop down to the education, we have 86.5% has high school graduate or higher. And the median household income throughout the state is $47,212. And then persons below poverty level from 28 to 2000 is 16.7. So to dive in deeper on the epidemic in Florida, this slide is going to show you that population in 2015 ranked us 3rd in the nation, 2nd in the nation for newly diagnosed HIV infections in 2014, and 1st in the nation in 2014 for newly diagnosed AIDS cases. 56% was white, 16% was Black out of that number, 24% Hispanic, and 4% other. The point of this slide is just to show you how we, in all of our presentations, how it shows that, we have to do greater work with our Black population, because it seems like that Blacks are disproportionately impacted in all of our states when it comes to HIV and AIDS. So this is why we all join AAHU. This is why we do the work that we do to make a difference in our own community. So in the state of Florida, and I'm sure in all of your states as well, you have targeted populations. So these are our non-targeted populations, and this drives the work that we do locally and nationally. The first is Black heterosexual men and women, white men who have sex with men, Black men who have sex with men, Hispanic men who have sex with men, Black injection drug users, Hispanic heterosexual men and women, white heterosexual men and women, white injection drug users, and Hispanic injection drug users. So with our BTAN chapters, yes, we know that BTAN focuses on the Black community, but BTAN in both Melbourne and Broward, we also include these targeted populations because this drives the work that we do as well.
Okay, the HIV prevention needs. Although Florida counties provide a range of HIV prevention, testing, and care services, based on our needs assessment for Florida, while the list of available services is comprehensive, there is still a need to improve communication of service locations and availability of them in each county. In addition, further services is needed in order to offer better assistance and funding health insurance co-payments for people living with HIV and AIDS, and mental health and substance abuse services is needed to extend and better incorporate the services in our area. Some of the services and resources that we have in our area is listed here. Some of the treatment services. In the state of Florida, there are services offered to people living with HIV and AIDS, and prevention services for individuals that are vulnerable to the disease. Although details of the service and resources being offered may be structured and different in each Florida county, all counties offer and may be structured differently in Florida County. All counties offer treatment and prevention services. Services and resources. This is prevention services. We have outreach. We have condom. We give out condom distribution, risk reduction sessions, serodiscordant and couple services, and the PrEP referral programs. Now in Broward County, there is not one prescriber that prescribes PrEP. We have to go to Orlando to get PrEP. So in June, we have our PrEP summit on June the 14th, and it's going to be huge because we brought in a lot of speakers from the Orlando area so that we can get the providers. Normally, we have a lot of community-based programs, but we are targeting services so that we can get them to buy in, because that it's 60 miles away to go to Orlando. And I just think that you should have to go to get PrEP, so that it should be somebody in our county that provides the PrEP. So the summit is going to be a great thing in our area.
Yes, and to just talk more about PrEP in Broward County, fortunately, we do have physicians that are prescribing PrEP. In addition, we have agencies that serves as clinics that offers PrEP prescriptions. They also offer assistance with paying for the labs that go along with taking PrEP. So fortunately, we have a couple of agencies in our area that are working with the PrEP program. In addition, just to mention too, because we just recently had our PrEP Summit, and our PrEP Summit in Broward County was very successful. We had over 130 something people. Black AIDS Institute, of course, attended the thing, our summit, and we also had presenters both nationally and locally come and present on various topics relating to PrEP in the Black community. So now we're talking about the Black community. Let's jump into BTAN. And I know we may have some online viewers who are not familiar with BTAN, so we wanted to just give you a brief history on BTAN. It's a national coalition of networks. Currently, it's in 17 cities and 14 states, I believe, and they're increasing by all of the AAHU fellows who are building chapters around the nation. BTAN is an enterprise comprised of health department, leading ASO organizations, community-based and faith-based organizations, experienced HIV clinicians, the Center for AIDS Research, and most importantly, people living with HIV and AIDS. It's very important that we engage our community members in our BTAN process. So to dive in further on the mission of BTAN, I'll just go over it briefly. And the mission of BTAN is to produce and support a nationwide network of highly trained Black treatment advocates who will serve as educators and opinion leaders in each of our communities, provide a pipeline of trained Black Americans for community advisory boards, facilitate expanded Black participation in clinical trials, and increase early utilization of appropriate treatment, and also improve treatment adherence in our Black communities. For BTAN Broward, so in all of the BTAN chapters, there are 4 major project areas that each of us have. Some of the chapters add additional project areas, but for BTAN Broward, we just focus on these 4. And that's treatment education, patient navigation, disclosure, and advocacy.
As well, BTAN Melbourne also uses these 4 project areas: treatment education, patient navigation, disclosure, and advocacy. But we also added some additional ones. We have a faith project area. We have a spokesperson at one of the local churches, because that's been one of the biggest successes for our BTAN Melbourne, was collaborating with churches. So we actually go into the churches and do our testing events. And we have one church in particular, which is Mount Moriah Baptist Church. They receive us with anything that we want to do. Any type of event, they do the food, they do the breakfast, they give us the space, and they don't charge us anything. We actually even have some of the BTAN members that's a part of that church. So it has been huge for us in Brevard County, having the assistance of the ministries, because I know a lot of people, other AAHU fellows, say that they don't have that support in their cities, and we are fortunate enough to have it. And I think that we broke down some barriers and kicked down some doors. We're able to go into the local churches, and it's been huge for us. We also have a social networking project area. We're going to design a BTAN page on Facebook, Instagram, Twitter, and with current events and current articles. We also happen to have the pleasure of having a professional consultant with Dr. Ronald Cathcart. He's part of the host organization. And so we're going to have a question and answer session on our page. Also, we have a youth group as well. And we're going to be doing events that attract youth, such as hip hop events, sports events, LGBT, and the national programs. So we added a couple different ones for our area to tailor what we need.
So now we need to advance both of our BTAN chapters. We've both been in existence for a few years. So let's talk about the background of each of our chapters. So Broward County BTAN was developed in 2012 With 58 members, the chapter was originally formed by Community Access Center and the Department of Health and Broward County HIV Prevention Program. To date, BTAN Broward has over 94 members who have attended at least half of our standing meetings. We have a standing meeting the first Tuesday of every month. And since the chapter's development, we have not canceled a meeting. This is a standing meeting that we have every month. The Broward BTAN chapter is structured to involve people living with HIV and AIDS in the planning and delivery of the services that we do to ensure that the voices of people living with HIV and AIDS are heard, and to maximize their involvement as peer educators, care navigators, and mentors for the local community of Black people living with HIV and AIDS. Our Broward County BTAN chapter is an advisory group of our Broward County HIV Prevention Planning Council. So our chapter is built into the Planning Council. The Planning Council, fortunately, is able to provide us with logistics assistance, TA with our programs that we have, and we even have been lucky where our monitoring and evaluation consultant for the Department of Health in Broward County assists with developing evaluations for all of our events, and then she'll analyze it and give it to the members of BTAN and our community in general, the findings of her report. Just to highlight a few of our highly attended events that we have in BTAN Broward so far, because it's a huge accomplishment, is our annual high impact community barbecue. We have been doing this now for, I believe, 3 to 4 years, and all of them have had over 300 residents in attendance to this barbecue. This barbecue is to encourage testing, of course. It encourages treatment if you are positive, and it's a safe place at our local YMCA. Well, all of these parents and family members and the community in general can come to this place, have a list of resources available. Majority of our ASOs participate in this, so all of the resources that's needed is in that room. In addition to other resources, Walgreens will come and do blood pressure screening and other services. So this serves as a venue once a year that we invite the entire community in an area heavily impacted by HIV to just come out. We feed them, we talk, we have a program, we encourage testing. And usually with over 300 attendants each year, we can range between 75 to 100 new people getting tested for HIV, which is a great accomplishment as well. In addition, we have Black elected officials luncheons, and we use this to inform local leaders on the emerging HIV/AIDS prevention, care, and treatment issues in order for them to have the knowledge and tools to make policy changes and advocate for the reduction of disparities in the Broward County community. We also partner with Black churches annually to host events at their churches to increase awareness, provide information on HIV treatment, and use that as an opportunity to recruit additional members and invite others to BTAN community events. I already mentioned the BTAN Prep Summit, and of course, as a AAHU Fellow and a BTAN co-chair, we constantly are planning HIV science and treatment training to educate, to make sure that not only our BTAN members, but our HIV workforce in Broward County are up to date with their information, because we're all serving the same population. So we just want to make sure that everyone is educated with the latest information that's coming out on science and treatment. So we're constantly doing science and treatment trainings. To go into our Broward structure. Broward structure is a little different than other BTAN chapters, right? From the very beginning, as I mentioned in 2012, it was developed in partnership with the Department of Health in Broward County. So not only do we have our host agency co-chair, which is currently Patricia Flournoy, she's part of Broward House, but we have a government co-chair, that's the role that I play. And then also we have a secretary, Shalisa Hafley, and she's another part of one of the largest hospitals districts in Broward County, so it's great to have her at the table as well. This is just to showcase some of our partners for our events, our activities, and each of these organizations also are part of BTAN Broward. So not only do they assist the chapter financially in providing services and stuff to our community, but they also send a member of their organization to sit at the table and help us plan these activities. A few, we have Coca-Cola around the table, Broward Health,
Positive Healthcare, AAHU, Broward County, Florida, Healthy Mothers, Healthy Babies. We have our DPI Leading the Change, which is part of our Broward Schools District. And Broward County also, just to mention that, since we have them up there, that we have a sexual health curriculum. And I think we are only 2 cities that CDC awarded this grant to. Yolanda?
Okay, so advancing BTAN Melbourne. So give you some of the background on how we got started. BTAN Melbourne initially started out as the African American HIV Stigma Reduction Coalition in 2012. During John Curry's, which is our co-chair, a host agency co-chair, he was part of the BAI, so he was the part of his community mobilization college, and that's what he was tagged to do. Officially, the name changed to BTAN Melbourne in 2014 during his Science and Treatment College session, which aligned with the course assignments. Currently, we got 35 members, which include people living with HIV, community members, and faith leaders who are passionate about educating our African American community on how to reduce stigma, raise HIV awareness, reduce new HIV infection, and engage Black churches. Many are voting members of the Area 7 Central Florida Planning Consortium and have attended state integrated prevention and planning meetings. Some of the successes that we had, I mentioned earlier, is that BTAN Melbourne has partnered with faith leaders and churches to reduce stigma and educate our community. One of the most successful partnerships with BTAN Melbourne has established is with Mount Moriah Baptist Church. They was the first church to partner with BTAN Melbourne, and they are always available to help with our training, meetings, and programs. They have been our biggest support when it comes to providing a facility to host events and preparing food to serve. They have been the perfect model for the other churches in our area to follow. And I must say it's working, because now we have since partnered with 3 churches that we can contact at any time for any event that we have, and they will assist us in that event. We have actually gone into over 30, 40 churches in the area, but those 3 main churches will help us out with any event at any time. We have initiated some dialogue and conversations with the Broward County schools. And currently in our school system, they don't talk about HIV. But we was at a community event, and it was a teacher that was there that came up and was interested in what we was doing. He had high school students, and that's part of his curriculum. He wanted to write us into his curriculum. So we having some dialogue and conversations about going into the high school and presenting some of the HIV information and awareness. Currently, we got 7 members who are state certified testers, and they are community members. The majority of the BTAN Melbourne is community members, and very few of them work in services. So everything that we do is based on community. Some of the challenges that I think that we have in our community is sustainability and membership, and keeping members engaged in the fight against HIV and AIDS. BTAN Melbourne is actually seeking a stronger relationship with our county health department. We're in Area 7, which comprises 5 other counties, which is Orange, Osceola, Lake Seminole, and Brevard County. And we get a lot of support from Orange County, which is the Orlando area, but our direct county don't support us as much as we would like for them to. So we've been trying to form a partnership with them. And also we would like to collaborate more with a National AIDS Education Center in our region, like the University of Miami, University of South Florida, or clinical trial research, to give us, our chapter, more resources outside of the state health department. This is our structure. We have a host organization, which is Unconditional Love Incorporated. Then we have a host co-chair, which is John Curry, and then I am the community co-chair, a AAHU fellow. So that's my position. And so the Melbourne BTAN chapter is structured to involve community members, faith leaders, and people living with HIV and AIDS in the planning and implementing of the mission of the Black Treatment Advocate Network in the Black community. And so these are some of our partners that we partner with. United Kingdom Kingdom Life Church, the City of Melbourne, Merck, Unconditional Love, Mount Moriah Missionary Baptist Church, the United Way, the Heart of Florida United Way, which in Orlando, where we had a planning meeting at on a monthly basis. Woodstock Hospital, Venus, which is a hospice care. Any of these agencies, anytime that we need anything, they support us with food, with the events, with buildings, and we got a great network of partners.
So engaging traditional Black institutions for both chapters have never been an issue, as you see by looking at our partners that we both showcase. We both as co-chairs are actively engaged with social networks and utilize our personal networks and connections to engage these institutions and being a part of both our chapters, BTAN Broward and BTAN Melbourne. We have strong ties with the National Panhellenic Council organizations, Black lawyers associations in both of our counties, and additional Black social groups around our county, such as the Red Hatters. I don't know if any of you are familiar with it, or the Black Hatters in the Melbourne area. We utilize all of these social groups to build, advance our chapters, to join our chapters, to spread the word about our events and activities. So that's the great thing, that we have strong partnerships when it comes to engaging traditional Black institutions. So talking about traditional Black institutions, now it's time to jump into our BTAN project plan that we developed based on being an AAHU Fellow. As Yolanda mentioned in her opening introduction, that not only do we have a passion for engaging our Black population as a whole, but we share with the passion about making sure that not only that we, keep in mind about our Black brothers, we know that they have a disproportionate impact with the virus, but we also want to make sure that women are a part of this conversation and that we're not forgotten, even though our numbers may be decreasing. We want to make sure that they steadily decrease and that women are a part of the conversation. So that developed our project plan for AAHU, which is called SISTA Speak. And our project for AAHU, to give you our problem statement, is that more Blacks in Florida are living with HIV than any other racial or ethnic group. HIV case disparities are more evident among Black women. To address HIV disparities among Black women, a holistic health approach is needed in order to empower Black women to increase their HIV knowledge, self-advocacy, HIV testing, mental health services, and housing accessibility. This is needed in order to address why 63% of Black women represent HIV cases each year in Florida. So that goes back to focusing on our brothers, but still remembering our sisters.
And some of our vision and goals for SISTA Speak. SISTA Speak will be a dual Florida County project between BTAN Broward and BTAN Melbourne, which has been developed to address the disproportionate impact HIV is having on Black women. The program is designed to have activities that will be under each project area: treatment, education, patient navigation, disclosure, and advocacy. Both chapters will implement a SISTA Speak ambassador program that will encompass developing community partnerships, community outreach, and a directory of treatment resources with key agencies and contact people, a social marketing campaign, HIV testing, educational summits, and face-to-face group activities with personal stories and testimonies in each group. Our goal is to have an ambassador program implemented by December of 2016 with over a combined total of 60 ambassadors recruiting women to empower women on HIV and AIDS. These ambassadors will assist with partnership development, community outreach, and engagement, social marketing campaign, HIV testing, recruitment of additional women, educational and empowerment summits, and plan awareness day events around these. The BTAN project plan is to target this population, both chapters were engaged fraternities, faith-based organizations, Black women, and social and professional groups in both counties. Krystle earlier went over some of the partners that we anticipate working with, such as NAACP, National Black Lawyers Association, MAK Coalition, the Black Hat Divas, and the Red Hatters, to name a few.
So now we're at the process and outcome and evaluation, because we know that every program needs to have evaluation component built in. And just to give you a quote by Forge WH regarding epidemiology, the reason for collecting, analyzing, and disseminating information on a disease is to control that disease. Collection and analysis should not be allowed to consume resources if action does not follow. So this is our evaluation plan. At every BTAN training or event, evaluations are used to analyze attendees' knowledge on the HIV science and treatment, and to view what their thoughts on the actual planning and their expectations of the event. We do not have an event if evaluations are not a part of it, and that's for both of our chapters. Evaluations are used locally to determine future trainings and to develop presentations that our community members may be in need of when it relates to HIV prevention and treatment. So right off the bat, in the very beginning, before we even roll out the program proposal that we have, when we recruit these women, that's the first thing that we're going to assess, is we're going to do a pre-evaluation to see where we're starting off at. We want to make sure that because these women are going to go out into the community and educate other Black women where they live, work, play, and worship on HIV and AIDS, that they're equipped with the knowledge needed to take this information. Because we all know if one person gives you the wrong information, you're not going to go to them as a source again to give you wrong information again. So that's the start point of us, is to make sure that the women that we are recruiting are educated on the HIV/AIDS science and treatment, and also what resources are available in their particular area. Okay, so now we're coming to the end, but you know, we said all of this about our experience with AAHU, what we're doing in our individual areas. And it all leads us to the success we have had in this fellowship program, that we're only a couple of counties away. And I met my sister Yolanda by attending this AAHU fellowship program. And from that, our chapters, you know, even with our prep summit, our sister BTAN Melbourne chapter, you know, drove down to Broward County to support us. So that's a success within itself. Just meeting your other colleagues when you're doing this work, and just knowing that you have that support in your same state, that we can call on them and they can call on us, and we can share resources and share ideas off of each other. And she can do something in BTAN Melbourne, and I can take that same program and implement it in BTAN Broward, and vice versa. So just the relationships that we have developed by attending AAHU. As Donna mentioned in the presentation before, all of the traveling back and forth, especially with family and work commitment, it's a little much. However, it's so rewarding at the end to just have the opportunity to just come and learn more and take the information that we're learning and take it back to our community.
And she pretty much summed it up, because the first success for me in this whole thing is being accepted. Being a community member, not working in direct services, doing nothing about what I'm doing. It's like, why am I doing this? Why do I want to learn something that's new? I don't know, but I am into learning. So for me to just be accepted and not be doing this work, that was huge for me. The national level of networking, I met some great people in this program. I met some friends. I met some family. We all family now. We got a connection. I think that we already talking about meeting up next year, what we gonna meet as a group. So that's, to me, was great. And then to receive education from a prestigious school like UCLA, and then the leadership of the Black AIDS Institute, that instilled something into me, and it gave him a skill set that I did not possess. Now that I have, I can go back to my community. When I did my first training, to get the feedback from the people, because, you know, everybody said, oh, she's going to LA, she going on vacation. It was not a vacation. So when I came back and I was able to talk about what I learned in the science and treatment college, somebody said in the training, "Oh, she know what she talking about." Yes, I had to work, and not to be in this field and was able to grasp it. To me, that was huge. So I am an example of my community, and to be able to take it back to my community, and not working in the field to me is huge. So, because I'm what they look like, so that's one of my biggest successes.
So in conclusion and future mobilization recommendations for Broward BTAN, our next step for our chapter is to re-engage members that may have been missing from the table for a couple of meetings. That's always important. You want to make sure that your members around the table are engaged and they believe in what you're doing as a group. Because at the end of the day, they are volunteering their time for BTAN. So we want to make sure that we constantly are re-engaging them, making sure they're motivated and empowered to continue the work that we do in our community. Yolanda?
The next step for BTAN is to continue our testing events, educating and awareness, being a community-based organization, because we mostly got community members. We actually, at the national testing last year, found it reactive. Like the host organization hadn't even found one. Our group of community members found one. That was big for us. To be able to now have your peers look at you and validate you and solidify the BTAN group and the work that we're doing. So we want to continue to learn and grow by going to the conferences, the national conferences, such as USCA and National HIV Prevention, and any opportunities that can come along that we need. So another thing is BTAN is looking to collaborate with local churches to do a drop-in center. We want to provide services of HIV testing in the heart of our community. There's not actually where somebody can go around the corner where all the drug people are, you know, people that's the street walking people. There's no place. But we got our church, our host, one of our faith leader churches directly in the heart of the community. So we want to open up a drop center. So that's one of the things that we were looking into doing. And also that we have formed a partnership with Krystle Medical Training Institute. What they do is they have nurses, RNs, CNAs, phlebotomists, and they're actually going to be a part of our prep summit. We just partnered with them, and they're going to come in, and they're mandating that they're all of their students, there's going to be a clinical day for them, so they will be at the prep tour, and that's huge for us to form that partnership with them. So hopefully we can establish some type of MOU with them, memo of understanding, and come together and do some work in the community.
So this is just to show you our BTAN members, because it's more than the co-chairs standing here. And this is the annual barbecue that this is a partner and member of BTAN Broward, Allison, and she's with Merck. She also comes into the Melbourne area and do presentations for their chapter as well. And the top pictures just showing our members working, breaking out into 4 project area groups that we mentioned, because before we end every meeting, we divide up into our 4 project areas and meet about different activities and action plans that we have collected and gathered as a group to make sure that we're doing exactly what it is that we said that we were going to do, and it's just not being on paper.
And this is some of the BTAN Melbourne members. Actually, this was my first training that I was charged to do back in September, and it's just some of the meetings, people that was there at the meeting. And this is BTAN Melbourne.
And we are at the end, but before we take questions, of course, we definitely want to thank, at least I do, want to thank the Department of Health in Broward County HIV Prevention Program staff, and of course my wonderful boss, Ms. Evelyn Ula, for allowing me to participate in a program such as this, because there's a lot of work into when it comes to AAHU, and just having that support and knowing that the team is there to support you. They'll answer an email, they'll take a call, they'll assist a community member. You know, I'm thankful for all of the support you have given me throughout these 9 months, and thank you for allowing me to participate in AAHU.
And on behalf of BTAN Melbourne, I would like to say thank you to our host organization, which is Unconditional Love Incorporated. They are always there whenever we need them for any activity and event. And then my co-chair, John Curry, he a pain. He always calling me. It was like, I got a job. This is not my job. You gotta call me later. But I love the deaf BTAN. I don't know where it's gonna take me. It feels like I'm changing fields because I currently work with local government. It has nothing to do with HIV and AIDS. So kudos to him for keeping me engaged.
Ben. No questions? Great, hearing none, we are done. And we'll pass it on to our BTAN Jackson, Mississippi, after lunch. All right.